Shabir, I think we can start.
Yes, sir. Good morning, everyone. I'm Dr. Shabir Ahmad Khan, final year DRMP training. And today we are going to discuss controversies in renal replacement therapy. 5 important controversies with regard to evidence we shall discuss today. So the contents of this topic are the timing of RRT, whether early RRT is beneficial or late RRT is beneficial. Then the second area of interest is continuous RRT versus SLED, anticoagulation of choice, and then the fourth point is whether a low dose CRRT or high dose CRRT should be considered. And finally, a few slides on role of extracorporeal therapies. So, with regard to timing of RRT, we have these major trials. The first trial was Baumann et al. Conducted in 2002. Then the ELAN study, the AKIKI study, IDEAL ICU study, START AKI study, and the lastly AKIKI 2 study. So we'll see the details of this study and we will finally conclude with regard to the timing of RRT in AKI. So Baumann et al. Conducted a study in 2002 which involved approximately 106 patients who are severely ill on ventilator support and were in early AKI. So the study consisted of 3 groups. One group received high volume hemofiltration early, another received low volume hemofiltration early, and the third group received low volume hemofiltration on a later time. So the results showed that the survival rates at 28 days were similar across all groups, and interestingly, starting hemofiltration early or using high volume ultrafiltration did not improve the outcomes in terms of survival or kidney function recovery. So the most important point to take from this study is it has found that the timing and the volume of hemofiltration did not significantly affect the survival or kidney function recovery in critically ill patients with early kidney injury. Then we have some major studies. Jamail, Elaine, AKIKI 1, IDEAL ICU, START again, AKIKI 2. So the Jamail study is one study conducted from India. The study populations were mixed. A total of 208 participants were there. The trigger to start early RRT was a burn value of more than 70 milligrams per deciliter or a serum creatinine of more than 7. And RRT is delayed until there are urgent indications. The primary outcome was in-hospital mortality, and almost 100% of patients in the early group and 83% of the patients in the delayed group received RRT. So the conclusion of this study was early initiation based on burn or serum creatinine is not beneficial. Then the second study was ELAN study, single center study, and the population mainly consisted of surgical patients, and total of 231 patients were included. Early RRT was initiated in KDIGO stage 2 patients, and delayed RRT was initiated when the patients entered stage 3 of KDIGO. The primary outcome was 90-day mortality, and this study has found a significant improvement in mortality when RRT was initiated early. So they concluded that early initiation of CRRT in surgical patients improved survival, reduce RRT duration and hospital stay. So we will discuss some criticisms and the points to take from each of these studies in the coming slides. Then the AKIKI study conducted across 31 centers consisted of mixed population, total of 620 patients. Early RRT was initiated in KDIGO stage 3 and delayed RRT for a burn value of more than 112 or oligonuria for more than 72 hours. So the primary outcome was 60-day mortality, and this study has found that early initiation of RRT has no survival benefit and may increase the risk of CRRTs. Here the point to note is the ELAN study and AKIKI study were almost conducted around the same time. Then we have IDEAL ICU study. This study was conducted across 29 centers, and it consisted mainly of patients with sepsis associated AKI. Total of 488 population, and early RRT was initiated when patients were in KDIGO stage 3. and delayed RRT 48 hours later or for urgent indication. The primary outcome was 90-day mortality, and this study also has shown that early initiation of RRT has no benefits. START-AK was one of the largest trials, which had more than 135 centers with mixed population, a total of 2,866 participants. And the early RRT was initiated when the patient was in schedule stage 2 or 3, and delayed RRT was considered for persistent AK 72 hours or later after randomization or for urgent indications. The primary outcome was 90-day mortality, and this study also has concluded that early initiation of RRT is associated with delayed renal recovery and RRT-related complications. So the START-AK study had clearly said that early RRT is not beneficial. In fact, it favored a delayed RRT approach, and it also has showed that if RRT is initiated early, it resulted in delayed renal recovery, and these set of patients had more RRT-related complications. Then we have AKIKI-2 study. We will discuss about this study in little detail in the coming slides. So when we are saying time, with regard to timing, when we are saying early and late, each of these studies had different time intervals wherein the defined time threshold was not linear across different studies. So in AKIKI study, the median time to start RRT in the early group was 2 hours. In ALIGN, it was 6 hours. ICU trial was 7.6 hours. In START-AK trial, it was 6.1 hours. Similarly, for late RRT group, AKIKI study, 57 hours. ALIGN study, it was 25 hours. And IDEAL ICU study, 51 hours. In the START-AK study, 31 hours. So there is no predefined time period between early and late RRT. It was mostly based on clinical triggers and patient clinical profile that has mandated either early or late RRT. So the points to note from these studies are Bowman-Tom study did not show any mortality difference with regard to early or late RRT. Then the Jamal study, it has concluded that early RRT did not improve survival. Then the ALIGN study, which has showed significant improvement with early strategy in terms of 90-day mortality. And the AKIKI study, which was conducted around the same time as ALIGN study, showed no difference between the strategies at 60-day mortality. Then the IDEAL ICU study, it also has not shown any difference between the ICU strategy. No difference between the mortality, 90-day mortality between early versus delayed RRT. So the Jamal study was one of the first studies to publish in India in 2013, and it has not shown any difference in in-hospital mortality. But the major criticism of the study was the study population did not represent the current pattern of the patients admitted to ICU. Shock was present only in 25% of the patients, and the mean SOFA score was as low as 8, indicating that most of the patients were not really sick. So this study included, and one more flaw from this study was, this study included mainly patients with AK who had acute gastroenteritis and tropical infections such as malaria, leptospirosis, dengue, which generally have good prognosis. So this notion is supported with observed mortality, which was low in both groups. Then the ALIGN study, it showed significant reduction in 90-day mortality, an unusually large benefit considering the vast majority in the delayed group also received RRT. So the major criticism of the study is that it is from single center, and 75% of the population at baseline had refractory fluid overload, pulmonary edema, or standard indications for RRT. So the problem with this study was patients who already had standard indications for RRT were put in the late group, and that could have probably given us skewed results, showing that early RRT is benefited compared to late RRT. In fact, majority of the patients in the late RRT group had standard indications for RRT. Then comes the AKIKI study. In AKIKI study, in addition to delayed strategy, it has not shown any difference with regard to early versus delayed RRT. And in addition, it also has shown that delayed strategy with close monitoring of the patients enabled avoidance of RRT in at least 50% of the cases, and there was an increased incidence of dialysis-related complications such as CRRT in the early RRT group. So, similarly, the ideal ICU trial, which consisted mostly of sepsis-induced AKI patients, also did not show any mortality between the groups. The START AKI trial is the largest among all RCTs, and it was published in 2020. And this study, the point to take from this study is it firmly established that delayed initiation of RRT as the preferred strategy in AKI. And on the contrary, it has shown that early initiation of RRT is associated with increased risk of dialysis-related complications and delayed renal recovery. So apart from this, we have a meta-analysis which included 6 randomized trials consisting of 1292 patients. And it has shown that early initiation of RRT is not associated with improved survival. However, the quality of current evidence is low, and the criteria used for early and delayed initiation of renal replacement therapy are too heterogeneous among different studies. As I showed in the previous slide, each of these studies had different time definitions with regard to early versus late RRT. So far what we understood from these trials is that delaying RRT in AK is not harmful, and in fact may prevent complications related to RRT and reduce RRT dependence in the long run. So now the point is, can delaying the dialysis even further will continue to provide any benefits or not? So this was answered by the AKIKI 2 trial. So AKIKI 2 trial, mainly the question was, so delayed RRT is the approach now. So how much delay can be tolerated? Like how late is too late is the question. So this study was mainly conducted in 39 ICUs in France. It's an open label randomized study, and it included AKI patients with critical stage 3 with oliguria of more than 72 hours and burn of more than 112. So there are 2 groups. One is delayed group and the other group is more delayed group. So delayed group consisted of 137 patients and the more delayed group consisted of 141 patients. And the primary outcome was RRT free days at 28. So the conclusion of this study was, in severe AKI patients with oliguria of more than 72 hours or burn of more than 112 and no severe complications that would mandate immediate RRT, additional delay in RRT did not confer any additional benefit and was associated with potential harm. So it is saying that you can wait for a delayed RRT to some extent, but when there are urgent indications, you should not delay and it is potentially harmful. Some strengths of this study was this, the criticism of previous trials was lack of applicability to the real world. So the AKIKI 2 trial answered this by removing oliguria as the sole threshold, and there is less variability. And the trial attempted to reduce the variability in the timing of RRT initiation by setting specific thresholds for burn and removing oliguria as a sole indicator for dialysis initiation, as it was there in the previous studies. And the limitations of this study was the sample size was relatively small. It consisted of only 279 patients. And the cohort differences, the patient cohort in AKIKI 2 was not directly comparable to the prior studies, potentially affecting the generalizability of the results. Now, the debate over burn, the use of burn as a marker for initiating renal replacement therapy remains controversial, and the appropriate threshold is not definitely established. So this debate is still ongoing, whether burn can be used as a criteria for initiation RRT and what value of burn should trigger initiation of RRT. So taking the discussion forward, so we can now the current approach should be based on inclusion of some certain biomarkers and clinical criteria and with regard to safety of delaying RRT. The trial provides a reasonable assurance that delaying RRT in patients with stage 3 AKI, prolonged oliguria, and burn less than 112 without urgent indications may be safe and can help avoid harm in patients who may not require renal replacement therapy. So what should be the current approach? When a patient is in acute kidney injury and there are life-threatening complications, renal replacement therapy has to be initiated. However, when patients are not having life-threatening indications, we can use, while we optimize the hemodynamic parameters, we can use plasma NGAL or furosemide test, and based on that, we can make a decision. If the patient is FST responder, which shows that urine output of more than 200 ml per hour for the next 2 hours following a furosemide challenge, then in this case, you can wait and watch. In other case, if the patient is not a FST responder, can wait and watch to some extent until unless there are life-threatening complications. The life-threatening complications are potential of more than 6 with ECG changes, serious metabolic acidosis, refractory fluid overload, or non-renal indications such as crushing or rhabdomyolysis. In that case, watching further is going to be harmful, and at this point, you should initiate renal replacement therapy. So the second important controversy was anticoagulation in renal replacement therapy and which one to choose. So we need anticoagulation in CRRT to maintain circuit patency. So circuit clotting is the most frequent cause of therapy interruptions, which will result in lower than prescribed dose of CRRT. So we had the previous class in which clearly we have discussed regarding different anticoagulation agent of choices and their doses. So briefly, I'll tell. Systemic. So we have two options basically: systemic anticoagulation and regional anticoagulation. Systemic, with regard to systemic anticoagulation, we have unfractionated heparin, low molecular weight heparin, direct thrombin inhibitors, or no anticoagulation as using saline flushes. And lastly, serine protease inhibitors such as nefamostat, which was used in Japan. And then regional anticoagulation, we have SLED. So the KDIGO guidelines saying that we suggest regional citrate anticoagulation in preference to systemic heparin as the first choice of anticoagulation in patients with, in patients without contraindications to citrate during CRRT. And we suggest that regional citrate anticoagulation should be used in patients with contraindications to heparin during CRRT, grade 2C recommendation. And with regard to systemic anticoagulation in CRRT, KDIGO is suggesting use systemic anticoagulation with heparin or heparin derivatives when regional citrate anticoagulation is not available or contraindicated. So the recommended anticoagulation of choice during RRT from KDIGO guidelines was regional citrate anticoagulation, and unless there are some contraindications to citrate therapy. So here the point to note is choice of anticoagulation in RRT should be individualized and it should be based on the patient's clinical profile. So in patients with high risk of bleeding or pre-existing coagulopathy, RCA is preferred to no use of anticoagulation. And in patients with low risk of hemorrhage and not requiring systemic anticoagulation, here also RCA is preferred to no use of anticoagulation. So even if the risk of bleeding is high, because this is just regional anticoagulation, it is not going to harm the patient. So in these two cases, you can use regional citrate anticoagulation as the anticoagulation of choice. And in patients requiring systemic anticoagulation, ultrafractionated heparin is preferred compared to other anticoagulants. And in those patients with suspected or proven hit, it is better to avoid unfractionated heparin as well as low molecular weight heparin. And the guidelines suggest that alternative agents such as argatroban, dinoparide, fundaparinase should be used rather than not using any anticoagulation. RCA is also an alternate strategy, keeping in mind if the patient has any liver dysfunction that could cause citrate accumulation. So the third controversy to discuss is the dose of CRRT. So the dose of CRRT can be thought as the volume of blood purified per unit time. So the treatment dose is usually prescribed as an early exchange rate. So with regard to dose of CRRT, we have at least 6 trials. If you see the first 4 trials, Ronco et al. Study, Bowman study, Southern study, and Tolvani study, these studies are relatively small in number, and the protocol was not generalized, and the outcomes were differing between each of these studies. Then in the last, we have two trials, the ATN trial and renal trial. We will discuss about these two studies. So the Ronco study was the first one we have, and it compared different doses of continuous venous hemofiltration and found no difference in mortality when comparing a volume of 45 ml per kg per hour to 35 ml per kg per hour. And the other trials which we have in this table, like Bowman, Saudan, Tolwan et al. In these studies also, there are some flaws that these studies were relatively small and often conducted at single centers, limiting the generalizability of their findings. In contrast to that, we have two large multicentric trials, ATN trial and the renal trial. So these studies found no significant differences in mortality or kidney recovery outcomes when comparing high intensity, which means a CRRT dose of 35 ml per kg per hour, to standard intensity CRRT, which means delivering a dose of 20 to 25 ml per kg per hour. And the results of these two trials were also supported by 2016 Cochrane Systemic Review, which concluded that high CRRT doses do not have favorable impact on mortality or kidney function recovery in critically ill patients with acute kidney injury. Moreover, higher CRRT intensity was associated with increased risk of hypophosphatemia. So with regard to dose, the ATN trial and renal trial did not favor a high intensity CRRT. They favored only the standard intensity CRRT of 20 to 25 ml per kg per hour. But the problem here is when a patient is undergoing CRRT, so we would prescribe a dose of say 20 to 25 ml per kg per hour. But the problem is what percentage of patients are receiving the prescribed dose of CRRT. So if you see the Venkatraman et al., he reported that only 60% of the prescribed dose was delivered in patients on CVVHD. So if suppose in 100 patients, if you have prescribed 20 to 25 ml per kg per hour of CRRT, only 60% of the prescribed dose was delivered. So which is significant. And the Dorimi study, which reported that CRRT practices in critically ill patients, found that only 22% of the patients who were prescribed a total effluent rate of more than 35 ml per kg per hour received the full dose. So if they said that effluent dose of 35 ml per kg per hour was prescribed, only 22% of the patients actually received more than 35 ml per kg per hour. So there is significant difference between the prescribed dose and the delivered dose. So Chlorel del Grando et al. Discovered that the delivered dose was only 75% of the prescribed dose when measured by urea clearance in patients treated with pre-dilution CVVHD. And the decrease in urea clearance was attributed to the circuit downtime and pre-dilution. And this is the most common thing that we see in patients undergoing CRRT in ICU. Definitely there will be interruptions and the prescribed dose will not be equal to the delivered dose. Similarly, Zhang et al. Demonstrated that the delivered dose was only 9.3% lower than the prescribed dose in 60 patients receiving CVVH, and this difference increased over time due to filter degradation. In the first session, second session, third session, over a period of time, the prescribed dose will not match the delivered dose. So this is the point to understand. So how can we optimize the dose of CRRT now? With regard to volume, standard volume CRRT is beneficial. High intensity CRRT is not going to benefit. But we should also keep in mind that during CRRT, there will be continuous interruptions. It could be because of malfunctioning alarms, filter clogging, clotting, catheter dysfunction, or changes in bags or tubings. So there will be downtime definitely of 4 to 6 hours, or maybe say 3 to 4 hours. So during that time, the CRRT dose won't be delivered. So unfortunately, there are no current proven strategies to completely compensate for the decrease in delivered CRRT dose caused by the circuit downtime. So how to counteract this now? So to counteract this, it is recommended that to account for an average 10 to 15% of the circuit downtime when prescribing CRRT dose, which means that the prescribed effluent dose should be set at 25 to 30 ml per kg per hour, which is 10 to 15% above the recommended delivered dose. So which means that in order to achieve a effluent dose of 20 to 25 ml per kg per hour, it is better to set the effluent dose at 25 to 30 ml per kg, which is 10 to 15% above this. So that we will reach the target solute removal and target volume removal dose. So the conclusion is there is no evidence to support the average high-intensity CRRT dose, and the dose of CRRT should be adjusted to reach specific volume removal or solute removal. Consideration should be given to estimates of circuit downtime, as interruptions can attenuate the effective delivery of the prescribed dose of CRRT. And the dose delivering during CRRT needs to be monitored using some quality indicators, so that interruptions should be taken into account, and the CRRT, non-CRRT intake, output, everything should be taken into consideration. And accordingly, we have to finally titrate the dose of CRRT. We cannot stick just to 20 to 25 ml per kg per hour for patients who require especially more than 2-3 sessions. Then comes the fourth controversy with regard to mode, SLED or CRRT. So, SLED is a form of intermittent hemodialysis, meaning it delivered intermittently for a few hours in a single session, and the duration is typically 6 to 8 hours, whereas CRRT is a continuous therapy which will run for 24 hours a day in prolonged sessions, like second session, third session. We may go on until we try to shift the patient from CRRT to intermittent technique. And the intensity of treatment, SLED is considered a low efficiency dialysis method, whereas CRRT is considered a high efficiency dialysis method, and it offers higher clearance of solutes and fluid removal as compared to SLED. And with regard to hemodynamic stability, CRRT is generally better tolerated hemodynamically compared to SLED because of rapid fluid removal rate. And equipment and cost, SLED has the advantage that it is less complex and more cost effective compared to CRRT, whereas CRRT involves more advanced equipment and may be associated with higher cost due to its continuous nature and need for ongoing monitoring. So, this meta-analysis, renal replacement therapy modality in critically ill patients with acute kidney injury. This is a Chinese study, and it has found that no superiority of one particular RRT modality or anything in terms of renal recovery and short-term mortality in critically ill patients with AK. So, this study, Chinese-based study, it is a meta-analysis which compared the efficacy and safety of various renal replacement therapy modalities in critically ill patients with AK. It included at least 23 studies and studied the electronic databases for RCTs comparing different RRT modalities, including CRRT, intermittent RRT, hybrid RRT, PD in critically ill patients with AK. And they found no difference in renal recovery or short-term mortality among the 4 different RRT modalities. And the conclusion was no superiority of one particular RRT modality over another in terms of renal recovery and short-term mortality in critically ill patients with AK. PD patients exhibited worse fluid removal and better safety in prevention of hypertension than extracorporeal modalities. Then there is one more meta-analysis. This was based in Canada, and this meta-analysis also concluded that there appears to be no clear advantage for continuous renal replacement therapy in hemodynamically unstable patients. So, they evaluated at least 18 studies consisting of 1,564 patients, and the meta-analysis results indicated no statistically significant difference in primary outcome or overall proportion of renal recovery. There is no significant difference between the secondary outcome of time to renal recovery. And finally, this meta-analysis concluded that there is no clear advantage of CRRT over SLED even in the hemodynamically unstable patients. Currently, both modalities are safe and effective means of treating AK in the critically ill adults. So, what does the KDIGO recommendation says? So, the KDIGO did not recommend one specific RRT modality over another in terms of patient outcomes. The choice of modality should be based on local expertise, resource availability, and individual patient characteristics. So, the conclusion of this controversy is that there is no preference with regard to SLED or CRRT. You can consider any technique based on your local expertise, resource availability, and individual patient characteristics, and both most importantly on the targets that you want to achieve, both volume replacement and solute replacement. So this is what I said. The evidence comparing CRRT and SLED is limited and may vary based on study population, study design, and other factors. At present, no modality of RRT is considered superior in terms of mortality benefit or incidence of complications. The choice between SLED and CRRT should be individualized, taking into consideration the patient's hemodynamic stability, severity of AKI, desired intensity of dialysis, and the resource availability. The fifth controversy, extracorporeal therapies in sepsis. So, as we know, sepsis is a condition characterized by life-threatening organ dysfunction caused by body's abnormal response to infection. So, it consists of three critical components. One is the invasion of body with the pathogens, and the body's response to infection, and then starts the organ failure. So, we have different therapies that will address each of these problems. Okay, while pathogen and PAM clearance can resolve the body's initial response to infection, toxin inflammation and other disturbances may persist and continue to be problematic. So this highlights the need for broad spectrum treatment strategies that can address various targets. So as a pathogen enters the body, there will be initial inflammatory response that will result in release of inflammatory mediators. So which will reach a peak. Then the body's cellular immune response will try to contract this by activation of B cells, neutrophils, myeloid precursor cells. At the same time, there will be a decrease in HLA-TCR expression, T cell exhaustion, apoptosis of immune cell, leading to immunoparalysis. At this point, the patient can either recover or he may continue to deteriorate, while the humoral immune response to some extent may try to contract these problems. But eventually, the patient may or may not recover. So, to address this issue, the concept of extracorporeal therapies in sepsis came into picture. So, let us see few theories and rationale for offering extracorporeal therapies in sepsis. There are three important theories. One is the peak concentration hypothesis, the threshold immunomodulation hypothesis, and the mediator delivery hypothesis. So the threshold, the peak concentration hypothesis says that when a patient has infection, when the pathogen enters the body and it releases some cytokines, there will be a stage at which the cytokines in the bloodstream will reach their highest peak. So this hypothesis says that the rationale behind this hypothesis is that the excessive cytokine release contributes to harmful inflammatory response observed in sepsis. So if we target a therapy at a point where the cytokines in the bloodstream are at their highest level, are at their peak, this can benefit the patient, and this can help in attenuating the response. And probably this you can initiate therapies that can target cytokine removal. So this is the concept behind the peak concentration hypothesis. Basically, it says that when the cytokines are at their highest peak, target a therapy and try to bring them down to a lowest point, if not completely removal. So at least to a lowest point. Then comes the threshold immunomodulation hypothesis. So as we know, sepsis is characterized by dysregulated immune response, which includes both excessive inflammation and immune suppression. So when the excessive inflammation on one hand will be causing organ damage, on the other hand, the immune suppression or immunoparalysis will predispose the patient to additional infections such as nosocomial infection. Again, that will also cause organ damage. So the threshold immunomodulation hypothesis is a theoretical concept which says that there might be an optimal balance or threshold of immunomodulation which is required in sepsis management to achieve favorable outcomes. So it says that by offering certain immunomodulatory therapies, we can counteract we can balance the excessive inflammation and the immune suppression. So example of immunomodulatory strategies include the use of corticosteroids, immunoglobulins, cytokine inhibitors, or other targeted therapies. Then comes the mediator delivery hypothesis. The mediator delivery hypothesis in the context of extracorporeal therapies in sepsis, it refers to a theoretical concept suggesting that potential use of extracorporeal techniques to deliver certain therapeutic mediators or agents directly to the patient's bloodstream for modulation of the immune response. This hypothesis suggests that the extracorporeal therapy could be modified to allow for targeted delivery of certain immunomodulatory agents, anti-inflammatory substances, or other therapeutic mediators directly into the patient's circulation. So the previous two hypotheses, it says that removal of the cytokines or removal of certain inflammatory mediators to balance the immune system, whereas the mediator delivery hypothesis says that we can use the extracorporeal therapies to deliver certain immunomodulatory agent to achieve clinical response. So when a pathogen invades, there will be immune response and in the first stage, there will be pathogen invasion followed by release of endotoxin inflammatory mediators, and there will be immune response followed by sepsis induced organ failure. There will be a spiral of sequences which will be happening as soon as the pathogen invades the body. Initially, there will be inflammation, then followed by endothelial injury, which leads to vasodilation, capillary leakage because of increased permeability, and leukocyte activation, coagulopathy. In the final result of all this is multi-organ dysfunction in form of ARDS, AK, shock, DIC, and delirium. Now, there is something called the sequential extracorporeal therapy approach, the SET approach. So this states that we know that there are different stages of pathogen invasion, then release of endotoxins, and then production of cytokines and occurring of organ dysfunction, as I have shown in this slide. So the SET approach is basically to see if we can deliver each of these extracorporeal therapies at a different point of time, so that in the initial phase, as soon as the pathogen enters the body, in the so it says that SET approach says that in the early phase of sepsis, pathogen removal from the circulation can be achieved by using high affinity binders and cartridges. So these specific devices can target and eliminate the pathogens, with helping to control the infection before the production of endotoxins or cytokines. Then the second stage at which endotoxin removal, endotoxin production is high, the SET approach says that probably the circulating endotoxins, a harmful component of some bacteria, can be targeted and removed through hemoperfusion or polymyxin B absorber. Polymyxin B is a substance with an affinity for endotoxin, allowing for cytokine selective removal from the bloodstream. So after entering the body and production of endotoxin, the third phase will be release of cytokines. So the SET approach says that by using some hemoperfusion or sorbent cartridges, we can address this problem by removing the cytokines. And finally, when the patient had gone through all three phases and there is organ dysfunction, we have no other choice but to support the organs, which includes supporting the respiratory system, the cardiac and renal. So we call it MOST, multi-organ support therapy is the final choice when the patient has gone through all three phases and finally landed in organ failure. So the treatment of sepsis using extracorporeal therapies is viewed as sequence of interventions based on different stages of disease. And in the early phase of pathogen invasion, specific interventions like antibiotics, hemoperfusion with polymyxin B may be useful for source control and toxin removal. As the disease progresses and there is immune response, immune dysregulation, we have to consider a broader approach that can address this problem by removing the mediators using some solvents like CRRT, CYTOSORB, or HA330 or 380. So we have, with regard to sepsis filter, we have high cutoff membrane, polymyxin B immobilized fiber column, CYTOSORB, oXiris, and modified AN69. So high cutoff membranes, these membranes have been developed to increase the clearance of inflammatory mediators. And the pore sizes are 2 to 3-fold larger than the conventional high cutoff membranes, and 1/20th of plasma filtering membranes. So the HICOS study compared high cutoff membranes with the conventional membranes in sepsis patients, but found no significant difference in 28-day mortality, vasopressin requirement, or ICU length of the stay. Currently, there is no strong evidence to support the routine use of high cutoff membranes, high cutoff hemofiltration in sepsis, and the limitation is excessive albumin loss more when used with convective modalities. So currently, we are not in favor of supporting high cutoff membrane as a routine therapy in sepsis. Then polymyxin B immobilized fiber column. very famous by the name polymyxin. So polymyxin is antibiotic with potent bactericidal activity against gram-negative bacteria and also binds and inactivates endotoxin. So its systemic use in humans is limited because of potential nephrotoxicity and neurotoxicity. So to address this, we have come up with a filter called toramyxin. It's a plastic column with polymyxin B, which is covalently immobilized on surface of a polystyrene derived polypropylene reinforced conjugated fibers, and it enables the selective absorption of the endotoxins in the blood. So as the blood containing endotoxin passes through this microfiber columns, it gets absorbed on the polymyxin B coated filters, and it helps in removal of the endotoxins. So the thing is, the evidence supporting the use of polymyxin also remains mixed, and the EUPHRATES trial in North America showed less than 5% mortality difference in the per protocol population, but did not reach statistical significance. So few of the studies on polymyxin B filters, if you see, we have a European pilot study, the UFAS study, Japan registry, Abdomix, Japan registry, and the EUPHRATES trial. And most of these trials are suffered from lack of a standardized protocol, no defined cutoff on duration or number of sessions, and also these trials cannot be matched with the resource limited countries like India, wherein we cannot offer directly a extracorporeal therapy with the target of endotoxin removal using this type, because of the exceeding costs that happens in the first 24 to 48 hours of patient admission. And then comes the CYTOSORB. The CYTOSORB is the extracorporeal blood purification method that effectively reduces the excessive levels of inflammatory mediators. And the cartridge contains a polystyrene divinyl enzyme copolymer, which coated with the biocompatible polyvinyl pyrrolide. So basically, each bead consists of 300 to 800 micrometer in size, and each gram of material has surface area of approximately 40,000 meters square, which is comparatively high as compared to the polymyxin P filter. So it helps in removal of certain pro and anti-inflammatory cytokines, including other molecules such as bilirubin, myoglobin, exotoxins, and drugs. CYTOSORB has been licensed for extracorporeal cytokine removal within the European Union, but there are currently no specific recommendation for or against its use. Also, with regard to CYTOSORB, we have 3 important studies, but as you see, the number of patients were 20 in Frisky study, in Shadler study 97 patients, and Kogelman study 26 patients. The Kogelman study actually showed a good improvement with regard to vasopressor requirement. So the actual 28-day ICU and hospital mortality was 61%, 73%, and 0.77% respectively, compared to 89% as predicted by the Apache score. So this study showed some benefit with use of CYTOSORB, but again the problem comes with regard to countries like India, where we have cost constraints and we cannot generalize it and apply on all different set of patients. Then finally, the modified AN16 filter oXiris. This membrane is composed of polyacrylonitrile positively charged with polyethylene. So evidence supporting the use of oXiris is limited to just case series, indicating the need for more comprehensive studies. There is only one case series produced by Sham et al., which consisted of 6 patients with sepsis associated acute kidney injury who underwent oXiris CVVH, and they found that no significant difference in ICU and hospital mortality between the 2 groups. So the decision making with regard to extracorporeal therapies in sepsis, the patient is in severe sepsis or septic shock with acute kidney injury or without acute kidney injury. So with acute kidney injury, if patient had life-threatening indications, then we have to go for conventional blood purification techniques. Otherwise, if there are no life-threatening indications, we can wait for conservative management. And on the other hand, if patients patients with severe sepsis or septic shock with or without acute kidney injury. Here we can use extracorporeal therapies to address these problems of removal of endotoxins or cytokines. So septic shock patients with endotoxemia can be offered endotoxin removal or endotoxin adsorption using polymyxin B filter or oXiris filter. And septic shock patients with cytokine storm with IL-6 of more than 1000 picograms per ml can be offered cytokine absorption using oXiris, CYTOSORB, or HA330 or 380 filters. This is roughly an approach, not a recommendation. So the Surviving Sepsis 2021 recommendation clearly says that for adults with sepsis or septic shock, we suggest against using polymyxin B hemoperfusion, and it's a weak recommendation with low quality of evidence. And currently, there is insufficient evidence to make a recommendation on use of other blood purification techniques. So the conclusions of my presentation are: there is no benefit of early initiation of RRT, and the decision should be made based on clinical hemodynamic parameters, avoiding the risks of late initiation. No modality of RRT is proven superior over other, and there is no benefit of high dose RRT over there is no benefit of high dose CRRT over normal intensity CRRT. However, measures should be taken to match the delivered dose with the prescribed dose. This is an important point. And currently, regional citrate anticoagulation is the preferred one, except in patients with liver failure, because it may cause citrate toxicity or accumulation. And the role of extracorporeal therapy with adsorbent filters looks promising, but needs more evidence to incorporate in guidelines. Thank you.
Thank you, Shabir. Kadir, you want to say something? Kadir, you want to say something?
Srinivas, I don't think Kadir is there.
Okay, Sham, you want to add something?
I think, Shabir, I think you have kind of touched upon the various aspects or various controversies which are associated with renal replacement therapy. One, yes, with respect to timing, I think rather than going by just the creatinine or the burn value or fixed time, I think the determining point would be whether the patient has life-threatening indications for dialysis. That should be the main criteria for initiating RRT. The other point is you should not only look at that, but you should also look at what is happening to the non-renal organ dysfunction or non-renal organ functions. So if you have a clinical situation where your non-renal organ functions are stabilizing or improving, at the same time you have a clinical setting where probably the patient is not hypermetabolic or not requiring active resuscitation, then maybe those are the situations where you may still kind of have a wait and watch approach. But otherwise, if you have worsening or involvement of other organ functions, as well as ongoing need for resuscitation and a hypermetabolic state, probably early RRT would be beneficial. I think with respect to dose, we have got enough data to suggest that maybe going for high volume CRRT may not be beneficial. I think most of the studies have demonstrated that. So going with the conventional dosing of about 25 to 30 ml per kg per hour of CRRT would be the ideal thing to do. With respect to the role of extracorporeal interventions in sepsis or other organ failures, I think we'll be able to answer a lot of these in the first annual workshop, which we are planning to do on September 16th and 17th. I think those are the few points which I want to add.
Thank you, Shabir. I think for an exhaustive review. The only concern is about the SLED versus CRRT. So far, nobody has been able to define exactly what is the optimum duration of SLED for a critically ill patient who is hemodynamically unstable and has volume overload. So all the studies which have compared SLED versus CRRT are very heterogeneous. There are some studies which have SLED only going for 6 hours, some for 4 hours even, and some going on for 12 hours and 18 hours. So unless and until we have a definite definition of what is the minimum duration that is required for SLED and standardize that definition and compare head-to-head different durations with CRRT, we cannot say that SLED is not superior or SLED is inferior to CRRT. But as you said, the logistics of arranging for the machine, the disposables, the consumables, and the anticoagulation is a big challenge. So there will still be a place for SLED in this part of the world. And as you know, it is called as PIRRT. So rather than not offer the patient anything, something that is likely to give benefit with probably an escalation of vasopressors is what we will require. CRRT has its role, not necessarily from an acute kidney injury point of view, but for logistic ease of administration in patients who are on ECMO, for example. You can't afford to have a lot of disconnections and reconnections in the circuit. So in such patients, if the patient requires an RRT, there are people who still do intermittent hemodialysis, they still do SLED on ECMO, but CRRT probably is an alternative to such situations. Next week, actually, we were supposed to discuss cardiorenal syndrome, but because of some logistic issues, we had to prepone the talk on fluid assessment of fluid responsiveness by Dr. Kiran, because Dr. Kiran and Dr. Shabir are traveling to Turkey for presenting their original works, one on nutrition and shock and the other on hypertonic saline versus mannitol in ischemic stroke in the World Federation Congress. It's a proud moment for all of us that our boys are going overseas to present in an international conference. So to facilitate that, we have advanced Kiran's talk to next week, and Smita will do the talk on cardiorenal syndromes on the 29th after the break we take for Independence Day. So thank you all for joining. All those who have queries on this topic, may please post the questions on the groups from which you got the link to this webinar. We will continue to keep track of those questions and try to answer them to the best. The moderator of the session will answer the questions to the best of their abilities. We'll meet again on the 22nd of August after taking the break for Independence Day. Thank you very much. Have a good day.
Thank you, sir. Thank you. Thank you, Gonzalo.
Thank you. Thank you, Shabir.
Thank you, sir.